Good afternoon. This is Lauren Dunlap, Executive Director for Advocacy and Awareness for Immune Disorders Association, or AAIDA, in Charlotte, North Carolina, and I'm happy to host today's webinar on this sunny spring afternoon in Charlotte. And we hope you are having a very nice spring day as well. AAIDA exists to provide support and advocate for the greater than 25 million Americans living with immune disorders. AAIDA works to promote research and create better awareness of immune disorders. This is AAIDA's 5th of 12 educational webinars for 2021 and our first forum event. And today I will be joined by Dr. Michael Rigas, who is a Pharm.D, and he will be discussing liquid gold and open forum on IVIG. Dr. Rigas is the Chief Clinical Officer, co-founder, and principal at KabaFusion, an infusion therapy company dedicated to managing IVIG and other chronic and acute therapies nationwide. Prior to joining KabaFusion, Dr. Rigas was Associate Chief Innovation Officer for Pharmaceutical Care for Geisinger Health System and Chief Clinical Officer for VITALine CareSite Pharmacy Services. Dr. Rigas has served as the Senior Vice President of Clinical Affairs at Crescent Healthcare in Anaheim, California, and is a large alternate site pharmacy company specializing in infusion and specialty pharmacy therapies. Dr. Rigas graduated from USC School of Pharmacy with his Pharm.D degree and completed his residency at UC San Francisco hospitals and clinics in 1982. His areas of expertise include antimicrobial therapy, immunoglobulin therapies, nutritional support, and many others. Dr. Rigas has worked on standardized coding for infusion billing, universal access via patient assistance plans, and managing Medicare Part D issues in front of the California Board of Pharmacy and CMS regional managers. Dr. Rigas is also a member of the American Society of Hospital Pharmacies, the National Home Infusion Association, the American Academy of Neurology, and Clinical Immunology Society. And Dr. Rigas has also, this was a very neat point, in the last 20 years, Dr. Rigas has managed over and overseen the care of 15,000 patients who have received over 20 million grams of IVIG. Dr. Rigas, we are so pleased to have you this afternoon. Please proceed.
Thank you, Lauren, and good afternoon, everybody. Thank you for having me, and I'm happy that we can have this discussion today. Lauren and I have been reviewing the slides and presentation here, so we think this is going to be a two-part series. So today is part one, and feel free to send questions to Lauren by text into the GoToMeeting document here, and then we can stop and answer them if necessary right then, or we can save them up from the end. So I'm going to talk till about 1:40, and we're going to stop there so we have the rest of the time for questions, and then we'll pick up the second half when Lauren reschedules the second half and let us all know. So,
and do feel free, sorry, Dr. Rigas, do feel free to type in, questions you have, and we will try to get those answered in real time as well. But we also are blocking off a portion at the end of the program as well, just so our audience is aware.
So I have just a little housekeeping here. There are two next webinars coming in May 21st and June 23rd. You can see them listed here about Sjögren's syndrome and chronic illness. So please dial into those if you're able, because I'm sure they'll be interesting. So I wanted to put a picture of our leader during an infusion here. She sent this to me, so you may or may not know what Lauren looks like, but she's actually getting an infusion here. So we want to keep in mind this whole talk and my whole career has been dedicated to the management and benefit of patients. And as Lauren said, at this time of my career, since about the year 2000, I've overseen the care of about 15,000 people getting IVIG, and about 20 million grams of IVIG have gone into those patients. So I've had a broad experience, and I'm going to try to relate that to everybody today. So the agenda is, and things that we do today may not be in this particular order, but I first want to talk about what is IVIG, how is it made, what diseases can it be used to treat with, and what responses and side effects do you expect, what IVIG products are currently available, what do payers do to minimize their costs that negatively affect the patient, either by denial of your authorization or by causing you to have excessive out-of-pocket cost, and then an open discussion. And really, the really important thing of this talk, by the time we're done, we want everybody to be able to feel comfortable. They know a little bit more about what you need to know to assure that if you need IVIG for the rest of your life, that you're going to get your therapeutic goals met in a way you can deal with it, even though you may be in the middle of a ruckus, as we'll show you in just a minute here. So the presentation objectives, I'd like to have those: understanding the role of IVIG in chronic disease, understand the actions insurance companies, which we call payers, take to minimize how much money they spend, therefore causing you to have adverse, we have a typo here, adverse to the patient. Understand what patients can do to optimize their regimen, working together with themselves and people like Lauren and Lauren's organization and now me, and understand the role of reimbursement methodologies. And these are some acronyms you may never have heard of before, but I think it's going to be critical for anybody getting IVIG for the rest of their life or for a long time to understand this. So as things change or your insurance company tries to do various things to you, you know what's going to happen. And then as far as patient-specific outcomes or objectives, we want you to acquire the minimum knowledge about IVIG required to successfully manage your chronic disease. So here we're going to talk about what are FDA-approved diagnoses for IVIG and why is that important, how much it costs to the insurance company and why that's important, how much it costs to you, and the acronym there is for true out-of-pocket costs. That's TROOP, written that way as a standard abbreviation for the out-of-pocket cost that the patient experiences, the impact of your being an IVIG patient on your doctor's office, the impact of multiple formulations available in the USA on you and your doctor, and the impact of manufacturer shortages and payer formularies on you that may cause you to have to make changes in your therapeutic regimen. So I'm going to start now into the actual meat of it, because we've set these things up as goals and objectives. So let's first talk about how is IVIG manufactured. So it is collected by plasma currently, and right now there are two ways to do it. You can either pay people to donate plasma, which is called source plasma, and sometimes in the recent years there's been more than 10 million liters of plasma collected. They're predicting, there's another typo, supposed to be 460 in 2020. Sorry about that. And right now the people get paid $25 to $40 per donation, and that's usually given to college students and other people who think that is a reasonable amount of money to get paid to give a liter of plasma or a unit of plasma, and they can do that about once or twice a month. Now, recovered plasma is when it's voluntarily donated, and the last number I could find is old, about 7 million liters were collected that way. So paid is about twice as much as volunteered, and these are from blood donations and Red Cross and things like that. The IVIG yield per liter of plasma is higher from voluntary because those people are usually healthier, and typically the supply is constrained because there always is more IVIG grams that want to be sold than there is liters of plasma collected. So right now there's a law in America that says if you're going to sell IVIG in America, it must be collected, the plasma must be collected in America. It may be shipped to Austria or Germany or England to be processed and then shipped back to America to be sold and infused, but this dramatically increases the price. This was thought to be logical back in the early 2000s or late 1990s when the FDA thought that the American plasma pool was more pristine than others, say from India or China or other countries that would want to donate. That may no longer be reasonable, but that's currently the situation. And then a liter of plasma contains IVIG that's in it. It contains albumin, which is a plasma modifier that we use sometimes in the emergency room. It contains hemophilia factors that use for people that have hemophilia who are bleeding too much. And it also contains specialized biologicals and other products. So the analogy to a barrel of oil is frequently made. And we all know, having lived our lives in America. We know that oil prices go up and down and gas prices go up and down, and they make jet fuel, and they make kerosene, and they make all kinds of other things from oil. And usually whatever is the most important part of oil, a barrel of oil, is what sets the price for everything else. And right now, people who make IVIG make the most money on IVIG out of all the things that are in there. Sometimes they even try to give away albumin. The hemophilia factors are very expensive as well, but there's just a small amount of those contained, and there's a relatively small amount of hemophilia patients compared to patients that are getting IVIG. And as we said, the most impactful components of the liter of plasma, they are these things listed above, and they may change, but over the last 10 years, IVIG and hemophilia factors are the two most important parts that's coming out of when blood is collected and turned into the plasma. So the production issues are complicated because it takes about a year from the time you collect the blood from somebody by donating it. It takes about a year to see that as IVIG on a shelf near you to be used. So whether it's recovered or voluntary, the blood cells are taken out. If it's source or paid, then we use plasmapheresis, and the RBCs are removed and returned to the patient. And you can see again how much they're paid. And the impact on COVID-19 on plasma donors, that is a new phenomenon, and that is that the number of people wanting to donate in the last 3 quarters of 2020 and the first couple quarters of 2021 that we're in now, less people have donated than did before because they're afraid to get COVID or afraid to go out of their house, or they're under quarantine. And therefore, we think there may be a shortage of IVIG coming up in the rest of 2021 or even 2022, as the number of liters collected may be less. And also the fact that starting in right now around March or April of 2021, the first doses of IVIG were collected a year ago are now available, and some of them may actually have anti-COVID-19 antibodies, which would make them even more desirable to give to people. We haven't seen that happen yet, but we're thinking that may be something that happens in the future. So now the next important thing is, what is the FDA approved indications? So you may say these are very rare diseases here. Of the first 6 or so, these are all primary immune deficiency, and these are ones that many patients have. Then there's about 150 separate primary immune deficiency diseases. Only 10 of them, which these are 6 of or 5 of, actually FDA approved. The other 140, whatever's left, are not FDA approved for these diseases, and that's a big important factor, as we'll discuss later. Idiopathic thrombocytic purpura, that's a platelet disease. Chronic lymphocytic leukemia is a kind of cancer. Bone marrow transplantation is an HIV-infected children, as well as Kawasaki syndrome. And then finally, most recently, chronic inflammatory demyelinating polyneuropathy, CIDP, and multifocal motor neuropathy. Those were added in 2015 and 2018 or thereabouts. So this is the current universe of FDA-approved indications, and we'll talk about why that's important in just a few minutes. So now let's talk about the IVIG drug administration issue. Say that the drug is made, say the FDA has approved it. Now where can you get it? Your doctor has to order it, of course, and that is, we'll go into that in just a minute, the complications of that. But here you may get administered it while you're a hospital inpatient, which is not very common, a hospital outpatient, which is fairly common, a doctor's office, not so common, inside your own home, very common, an ambulatory infusion center that's not owned by the doctor or the hospital, somewhat common, but not that much because they can't bill various payers as easily as doctors or hospitals can. Then we have to talk about, if you get in any of these particular sites, how does that match the clinical need? Are you unstable? Does your doctor want to watch you while you're being infused? Or does your doctor want to watch you for the first couple doses and then move you to home after that to make sure you're okay for the first couple doses? Then there also can be a huge amount of regulatory and reimbursement issues that may come along with the site of care. For example, like a home infusion pharmacy like my company and the other ones like my company, We can typically only do it in the patient home. Our insurance companies will not let us do it in the physician office. They won't typically let us do it in the hospital outpatient. And so they're trying to constrain, the payer and the government tries to constrain and control. And so that may make a difficulty for the patient when your doctor may want to have started you in an infusion center to make sure it's safe and you do okay, and then transfer you to home later. Now, the next issue is the route of administration. Now, IVIG implies it's given by the IV route intravenous, but immunoglobulin is also available in a subcutaneous route, and that is under your skin, but not into a vein. So they both have different risk and benefits, and they have different implications for how much drug can be given and how often, and different implications for whether the patient has to do any work to set up his own sub-Q infusion and do it, or if a nurse is going to come and do it all if it's IV, and whether you can take it with you on vacation or travel with it. If you do it sub-Q, you have much more flexibility. If you do it IV, you're dependent on a nurse to come and do it. Then there's the first dose issues. That is, if you never had IVIG before, some companies won't do it to you, give it to you the first time at home. Some companies, like my company, will if you meet our criteria, which has to do with past allergic reactions and things. Some doctors want to get your first dose in an infusion center near a hospital emergency room in case there's reactions. Others don't. So right now it's very important to keep in mind, if this is a first dose, or if you had your first dose a long time ago, you may remember what happened to you, as people either said we can't do the first dose at home or we can. And then also the pumps required. So typically, if you're getting it IV, you're going to get it with a pump to put it in at a positive pressure. That requires a bag and the pump and training and tubing, and typically a nurse to do it, to put in the IV. If you're going to get it sub-Q, you put your own sub-Q catheter in your arm or leg, wherever you put it, and then you can connect it up to your own pump, which is much more simple. In some cases, just a syringe driver, as opposed to an ambulatory electronic pump, which has to be programmed and needs batteries. Okay, and then I put down here possible IV access devices usable for specific patient drug disease combinations. That is a mouthful, but it means the best thing for me and my company, and best thing I think for patients, if the doctor prescribes, I want this many grams of IVIG given every week or every month, and I want to be given IV or sub-Q, and then I want the pharmacy and pharmacist to figure out what the best catheters are, the best pump, the best tubing, all those other things that suit the patient's lifestyle, whether you're sedentary and mostly sitting, relaxing at home, or whether you're out and about, or maybe even playing tennis or going for a walk or working. All those things can get complicated, and we want to be able to choose all the right equipment. There's several ways to infuse it, and there's always the best way for each patient based on their lifestyle and based on their other issues. So now let me stop there. And
Dr. Rigas,
yes.
I just wanted to interject right quick. There was a question, and I think it kind of ties into your FDA approved treatment slide you had a few minutes ago.
We get it back here. Okay, go ahead.
Yeah, so well, I think you're going to dive into this early, but this is kind of pertains to that. So this question is from Ronnie, and she wanted to know why are insurance companies so hesitant to pay for IVIG for encephalitis of the basal ganglia? And I think that question kind of ties into that, and you might take a deeper dive into that later, but I just want to throw that out.
I will deep dive into it later, but I'd like to answer it on a surface answer right now, if that's okay. So, so Ronnie, think of this, and other patients on the phone, think of this. You've just been diagnosed with a certain disease, and your doctor wants you to get IVIG, and you have insurance, and so they forward the required information to that insurance company, and the insurance company then says, they look at their rules and regulations they've set up themselves, and they say, you know, do we want to pay for this for Ronnie? Do we think that's a good diagnosis? Do we think that Ronnie's actually going to get better if he or she gets IVIG? And do we think there's something less expensive, less costly than IVIG that Ronnie can get to make sure that they get that first before they decide to give something more expensive like IVIG? So all those things are called step edits. STEP edit. And that means the insurance company wants to give you and your doctor a series of steps you have to get through, almost like flaming hoops in a circus. So you've got to get through each flaming hoop and come out alive on the other side before you can go to the next one. And only when you get through all of them does you get your therapy approved then. And so in this case, the encephalitis, that is not an FDA approved indication. And that can mean several important or not important things. These FDA approved indications are the result of, say, 30 years of IVIG being given to patients. And in some cases, it's absolutely essential that you have IVIG. These primary immune deficiencies, most of the patients would either have a very difficult, highly infected life or die very early, and there's really no other treatment for them. But if you take ITP, there's other treatments. If you take CIDP, there may be many other treatments that could be tried before IVIG would be given. And in the world of these neuropathies, there's about 200 separate kinds of neuropathy, and about 15 always respond to IVIG. 15 sometimes do, and the other 170 never do. So the insurance company wants to make sure that they screen you out, so to make sure that if you don't have one of the sometimes or always kind, that is the 30 of those, that if you have one of the 170 that never responds to IVIG, they're not going to approve it. And so they're trying to control their spend, and they want to make sure that you and your doctor are not overzealous and thinking IVIG is going to be used for anything. Like there are over 1,000 uses for IVIG, and we see papers every year that talk about new and novel things that IVIG could help with. But it could be, there have been papers published on IVIG for fingernail growth, IVIG for hair growth, and IVIG for primary immune deficiency. So things that nobody would want to pay for, fingernail growth and hair growth maybe, but people want to pay for primary immune deficiency. So when you come along with a diagnosis that is not one that's FDA approved and not one that's commonly used, even if it's not FDA approved, then your insurance company is going to push back. They're going to ask, is it really a good diagnosis? Have you tried everything else? What else could be done for you? Is this something you could just live with? These are the insurance company, that's the way they act. And one last thing about FDA approval, that doesn't necessarily mean that it's the right thing. Like, for example, this chronic, the CIDP at the second from the bottom here, that was done in like 2015 by the company Grifols, who makes Gamunex C, and they did it, and they spent millions of dollars doing the test and the study and getting approved. And it was very important that they did, because now every insurance company has to give it for CIDP. So if it's FDA approved, the insurance company has to give it to you as long as you meet their criteria. Whereas if they had never got CIDP approved, then it would be on the same basis as like your encephalopathy, where it'd be up to them to decide. Really, they would say, if we don't give it to Ronnie, he might go in the hospital, run up a higher bill than if we give him the IVIG. So this is very almost actuarial in nature, and thrown in IVIG, pharmacology, the FDA, and the payer altogether is a very complex situation. So, Lauren, is that a good enough answer for now?
Yes, sir. Thank you.
Okay. All right. Let me go back to where I was. I talked about the sites of care. Now I want to switch to the pharmacology, and a lot of times the words we may be using today are not normal. So pharmacology means the study of the effects of the drug, and I use it in a broader sense to understand, besides the effect of the drug on the patient, where do we find the economics of it? That would be pharmacoeconomics. Where do we find how it actually works on your body? That would be pharmacodynamics. And then also the sort of cultural use of it. There is no name for that. But then I'm also going to talk about pharmacoregulatory. That is, what do the rules and regulations say, and how does that adversely affect the patient? So here I'm going to say, over 30 years, IVIG has been used for PID, primary immune deficiency, autoimmune neuromuscular diseases like neuropathies, pemphigoid diseases, which are autoimmune blistering diseases of the skin, and many other, as I said, hundreds of things it's been tried for. We talked about FDA approved indications. We talked about the products we'll see in a minute. We talked about right now, the average IVIG, it costs around, say, $60 a gram to make it, and they sell it to a company like mine for anywhere from $80 to $90 a gram for us to buy it. Then the insurance company is going to pay anywhere from 80 or 90, even to up to 180 a gram, depends on how smart or how nice that insurance company is. And so the whole economics of it is very perverse, as you might imagine. I'm going to talk about that in more detail shortly. So now it's also important to realize the reliability of obtaining the IVIG infusion reimbursement. If you turn 65 and all of a sudden get to become Medicare, like I just did, now Medicare is my payer. So if I was to need IVIG, and I had United Healthcare in January when I retired, before I retired, and now I have Medicare as I'm retired, the reimbursement structure to me and how much out-of-pocket cost I pay and the criteria for what's approved for me if I needed IVIG is very different from United Healthcare that I had in January to Medicare that I have in February. So the desired level of reimbursement to you as the patient, you're hoping for 100% reimbursement and nothing for your out-of-pocket. In many cases, you, the patient, and or you and the doctor together may decide you don't want to get it at home anymore, you want to get an infusion center, you may decide you want to get it opposite, you may want to go to the hospital to get it. So every time you make any change in whatever is happening to your program of IVIG, your payer, your route, your dose, how often you get it, any of those things typically is going to have some effect on your ability and how much ability to get it and ability to how much you have to pay to get it and who's going to be able to help you with it. Okay, and then also that goes along with the reliability of access to any given IVIG product. Let's say I was on IVIG and I love GammaGuard liquid, say, and there could be a shortage of GammaGuard liquid in the next month. And the GammaGuard liquids comes as 5, 10, 20, and maybe 30 gram bottles. Maybe all of them are short, or maybe only the 20 is short, and that could cause me trouble. It could cause my pharmacy trouble, or the whole drug could be short. I may have to change. I may have to call you. Somebody may call me as the patient and say, we're almost out of GammaGuard liquid, it's on shortage, so we're going to change you to, say, Gamunex C. And in conjunction between the pharmacy and your doctor. So you need to know this because it may be a change that affects you, and you may need to understand about this before it happens so you don't get very upset or concerned. Now, the next component here is viral safety, and you may, there's been more questions have come up since COVID, like, am I going to get COVID from getting IVIG? And so ever since about the year 2000, in America, all the IVIG products sold have had a 3-step antiviral treatment to them before the product is available for use. And that 3-step antiviral safety system is different from drug to drug, but the same 3 steps of one kind or another are typically done. Some even do 4 steps. And right now, we've not had a single patient since the year, say, like 1998 in America, and probably since 1998, maybe 500 million grams of IVIG have been given in the United States. Nobody's ever gotten a viral infection from getting IVIG. So the viral safety is not something you should worry about. Then next is the differences and similarities between IVIG products. And I always tell patients that the products are like 95% the same and maybe 5 or less % unique or different. And those can be very important to some patients, and they could be completely unimportant to most patients. And so many patients become obsessed with a particular brand or have had 3 brands in the past they didn't do good with, so they know that this particular brand they're on now is the only one that works good for them. And that may be true and may be reasonable, but it also maybe that's the brand that's now in shortage. So you have to have a plan. What am I going to do if my drug that I like the best is no longer available? What am I going to choose, and who am I going to tell that I had 3 other brands before that I didn't like for whatever reason because I got a rash or headache or something? And how am I going to make sure that the pharmacy and the doctor know that and I don't get something again that I had a problem with before? So, and then I talked about common side effects. I just mentioned a couple of those, headache and rash. Those are the most common. Some people flu-like symptoms the day or two after the infusion. Some people feel nausea and vomiting while they're getting the infusion. But by and large, most people, more than 98% of all the people I've treated, have very little or no reaction or side effects from the drug, and typically are more focused on the benefit of the drug that is keeping them having a normal life. And then I put here documentation and sharing of clinical outcomes with payers. It's critical that if you're a complex IVIG patient, that you are your best advocate. If you're coming with me or my company, we've been doing this for 30 years in various companies and now 12 years in KabaFusion. We've done millions of grams, as we just said, but the average patient that comes on doesn't really know what's wrong with them. They don't remember what they had before. They don't remember if they had headache from it. So you have the ability to be your best advocate here, to know everything that you can know about your own disease and what happened. If I got Gammaguard liquid in 2010, I didn't like it. I got Privigen in 2012, I did better. But then I switched to Octagam and I did really good. So probably 80% of the time when I get a new patient, I ask them if they've ever had IVIG before. If they say yes, I say, what brand did you have and how did you like it and how did it work for you? They either don't know at all or can't tell me enough detail to help me help them. So that's really important, that you keep track of your own health and your own side effects and your own outcomes. And if you tell me as the pharmacist, I don't like pick any drug, I don't like Privigen, okay, why didn't you like it? What happened to you? How long after the dose did it happen? Where did you get that dose? Did you get it in the hospital or doctor's office? How fast did that dose go in? So the more you know about how you've done in the past with any of these things, the better we can make your future.
Dr. Rigas, I just want to emphasize something you just said. Most of these products that are on the market, IVIG or subcutaneous, like you mentioned, 95% very similar, but there is a 5% that they are not. And I just want to emphasize, they are not interchangeable. They do have different various stabilizers, as you will point out here in just a minute. I don't want to mislead anybody that there's generic and there's brand names, right? These are not totally interchangeable drugs, and each has their own side effects.
I'm glad you make a point of that, because I want to make sure I'm not misunderstood here. So even though the drugs are mostly the same, that 5 or 10% difference can be important. So these should not be considered interchangeable. And when we get to the nomenclature, each one of these drugs has its own NDC number, National Drug Code number. In order for a drug to get an NDC code by the FDA, it needs to be considered unique. And if the drug is not considered unique, it may get a NDC number or J code that is for a group of drugs that are similar, but all the IVIG and sub-QIG products all have their own NDC number now. So every one of them is considered unique and not interchangeable unless ordered by your doctor to be interchanged. Now, I switched my screen. Can you see this specialty pharmacy solutions chart?
Yes.
Okay. Now, I don't want anybody to freak out, but after 20 million grams that I've overseen, this is what my brain thinks about. And so this is a chart, and I'll make it available to Lauren, and anybody who wants a copy can call her and she'll send it to you. This is a company called MHA Managed Health Associates. It is a company that we use as a group purchasing organization. They provide this chart every year in October. It gets updated every year in October. And this is the October 2020 version. And so here, the first table shows all the 10% liquid products that are given IV. And hopefully you see your product if you're on any of these here. There's a couple. This one, Astentiv, is very rare. And we don't see that except in a hospital for babies. But the rest, some are off the market. Bivigam's off and Plebigam's off, but they still could come back. We see Gammaguard Liquid, Gammaked, Gammaplex, Gamin-XC, Octagam, Panziga, and Privigen are the products shown here now. Now, it's important to note that these are the pharmacodynamic factors. What is it approved for by the FDA? The IgA content is a possible reaction that some people have if you don't have a lot of IgA yourself. If you give one that has a lot, it could cause you to have a reaction. The osmolality is how, like, salt water and ocean water is 350 milliosmoles per kilogram. And you can see most of the IVIGs are very close to that. So that means they're not going to cause a problem with your blood cells. Most of them have stabilizers. There's no problem stabilizers anymore. There used to be some problem once those drugs are off the market now. The pH, they're all in the range they should be, so there's no issue with pH. The product half-life, they're all about 4 weeks. In your body, they go half away. So if I gave you 100 grams today, at the end of a month from today, you'd have about 50 grams left in your blood. The viral safety process, that's what I told you about. Each of these has their own process, and there's either 3 or 4 steps. And we can just see some of them here. Solvent detergent means they precipitate out any viruses. Nanofiltration means they filter out the viruses. Low pH incubation means it precipitates viruses out as well. And there can be several other things. So usually these products have 3 or 4 of these steps in a row. And that means that by the time the product is ready for you to use, there is no virus left in it to worry about. Then the question is, what's it FDA approved for? And my screen's jumping. Okay, can it be given subcutaneous and IV both? Or is it only IV in this case? And we can see some products like this one here, I think is GammaGuard Liquid, and a couple are GammaKed or GammaNext. They're FDA approved, be given sub-Q or IV, but most are only IV. And then the dose, obviously the doctor and the pharmacist working on the dose, so we don't really need to look at the dose. And then here, infusion rate is important, the maximum rate, and then how long it's good on the shelf, either in a refrigerator or not refrigerator. And so these are important things to know, maybe more than you ever want to know, but the fact that somebody like me knows all these things, and your pharmacy or pharmacist should know them to make the best decisions for you. The next part of this thing is the 5% solutions, which are here, and there's a few kind of powders left that have to be diluted. And the only real powder that's left is GammaGuard SD, which is available for patients who have a low IgA, and this is on allocation only. You can't get this unless you have lab tests showing that you have a low IgA in your blood to begin with. And then GammaPlex and Octagam are both available as 5 and 10%. And then the last part of it is the subcutaneous products. And those of you on Cutiquig, Cuvitru, Hizentra or Hycubia or Zembify recognize those as the sub-Q drugs that only are sub-Q. And then the GammaGuard Liquid, GammaKed, and GammaNext C are also FDA approved to be given sub-Q or IV. So I want to stop there and see, I'm going to make this available to Lauren. This could be the discussion of, I use this chart I just showed you as the discussion to give whole hour, sometimes multiple hour lectures. So obviously we're not going to be doing that today. So I want to stop there and ask, so far we've talked about several features and benefits and attributes or characteristics of IVIG. It's very complicated, and I want to stop and see if there's any questions that anybody wants to ask before we move on to more about the IVIG itself.
Well, one thing I did want to point out, Dr. Rigas, is I think there's a misconception, and this isn't just a patient perspective, this is also a provider and a pharmacy perspective too, specialty pharmacy and industry, is that the sub-Q and the IVIG products have to be refrigerated. And that is something that's oftentimes misleading. And I explain to patients that that actually, expands the shelf life of the product. Do you want to just touch really briefly on that?
Yeah, so here, the chart I was just showing you, let me make it bigger so you can actually read it. Okay, and that little bit bigger, can you see that, Lauren?
Yes, sir.
Okay, so here, these are the IV products as happened. So GammaGuard Liquid tells us in the refrigerator, it's good for 36 months in its original bottles, and at room temperature, it's stable for up to 24 months. So the refrigeration only extends its stability to 3 years. So otherwise, in controlled room temperature, that would be considered no more than say 78 degrees room temperature, it's still good for 24 months. Now, that may or may not be important. A company like mine or other infusion companies will only send you typically a month at a time because we don't want you to keep it in your home. We may mix it already into a bag that may only be good for 2 weeks, or we may send you the bottles that may be good for up to 36 months in refrigeration, but we want to keep track of the patient's use of it. We don't want to send like a year's supply. We don't even want to send a month's supply in some cases, but typically we're sending a month at a time. But as Lauren said, it doesn't have to be refrigerated, but once we send it to your house, you're only helping yourself and your pharmacy company by refrigerating it. The only downside is that you have to take it out an hour before use and let it come to room temperature. Otherwise, it may not feel very pleasant when it's going in. So the storage is important. And if we mix it into a bag, like say, maybe Lauren maybe she needs 44 grams, and maybe we don't feel like sending her 2 20s and 4 1s. We might mix 44 into a bag and give it to her to make it easy for her. Then if we do that, then our bag that we made in our clean room is probably going to be only good for 2 weeks after we make it. And then refrigeration is very important, because if it gets out of the refrigerator before you give it to Lauren, then it may only be good for 24 hours at room temperature after we've made it into a bag. So the concept of refrigerator and room temperature storage is complex because it also has to do with, is it in the manufacturer's bottle still, or is it in a bag that's been made into an IV bag by the pharmacy? So those would be 2 important things you'd have to understand. So the best thing is leave it in the refrigerator, and you'll always have the best outcomes compared to not refrigerator, unless you don't have a refrigerator, unless you're going to be traveling. Then you can always call your pharmacy or call me and ask me, what do you think I should do with this if I'm going to travel to somewhere for a vacation or something like that, and the refrigeration could be more difficult.
Thank you, Dr. Rigas, for touching on that. I just wanted to say a couple of things. We're at about 15 minutes, and I was going to ask you if you could just touch on what the next session, the part 2 basically of this webinar is going to entail. Yes. And then I'm going to ask a couple of questions. Some are for you and some are for me.
All right, so here's the slides we have in mind here. So we got up to the pharmacology, up to slide number 12. And right now we have part 2 coming up down here, where we're talking about the more specifics of it, about the use by diagnosis and where it gets used in a hospital versus home. What I'll do is I'll move part 2 over to here like that, and then we'll start off where we left off. We're talking about this pharmacoregulatory storm that I talked about. That is how all these payer, patient, pharmacy, doctor, hospital, Fed, and state all can weigh in and have some impact on the patient in the middle. So right now what we'll do is we can stop right here, and then we can see part 2 is going to now include other items that we didn't talk about before. That is the referral process, which is important. Here is a slide to show when the doctor calls you from his clinic and orders it, what happens, what do we do, in what order. And this is like a 15-minute discussion by itself, because I want to make sure patients understand. So that's where we're going to be heading next time. And we have slides about more to talk about here, the supply and demand, the cost issues, the reimbursement structure is mostly what the whole second half is scheduled, because 2 patients that have identical disease, say they both have primary immune deficiency, both are say 50 years old, both have say 50 grams a month, one has Medicare, one has Blue Cross. The amount of out-of-pocket, all the other things that could go with it are very different. What's going to happen to the 2 of them? If those 2 patients met at a birthday party and compared notes, they would both be angry, because they would see that the other person got something better than them and the other person had something worse than them as far as their insurance and out-of-pockets and things. So we need to understand this, because the main goal of the talk is to arm the patient and their family with all the knowledge they need to keep getting their IVIG month in, month out for the rest of their life, and to be able to avoid and plan for problems that could occur down the road that you can't control, that could do with shortages, could do with pandemics, could do with out-of-pocket costs, could do with switching insurance or changing to be Medicare age, etc. So I'll stop there, Lauren,
Okay.
and we'll save this for part 2, and we'll open the microphones here or whatever for questions. So I'll sit here and be quiet, and I'll respond to questions however they come in to you or me when they get here.
Okay, the audience can type in questions that they may have. There's a couple that I can probably answer, and you can chime in if you would like, Dr. Rigas. So Ronnie had a follow-up question from earlier. She said that the good news is that her son's neurologist has gone to bat for her son and has won appeals, referring to the IVIG. However, it's not consistent for many states. There are a few states that have coverage for IVIG treatment. And I just want to point out that this is really a state by state issue. It falls on advocacy of the patients and who they lobby to on Capitol Hill, and who ear that it's taken to. So it's really a state by state process, but it's still going to be highly regulated. I think that's the short answer. It's just the patients and the parents of the specific patient population that you're referring to, Ronnie, and lobbying with the lawmakers in those states has a lot to do with what's approved.
And I agree with that. If Ronnie's insurance was Medicaid or Medicare, that would be the complete answer. Each Medicaid and Medicare may even vary by region of the country, but if it's Blue Cross or Blue Shield or the private care, then the lobbyist may affect that, but it's mostly what is Blue Cross. And earlier today I was on a different call, and they were showing a Blue Cross of, I think, New Jersey, and it had a 136-page document on what the requirements were and what was approved and not approved for IVIG. And it specifically showed these are the, say, 50 approved diagnoses and what you have to do if you want to get it approved for one of them. And if you don't, if it's not one of them, then they listed maybe 100 more diagnoses that we're not going to be paying for this now or ever. So if you think you have one of these diagnoses, don't even ask. So is it a complex situation because Medicare and Medicaid have a different set of regulatory requirements and rules, as Lauren has just mentioned, and the private insurers like Blue Cross, they are under regulatory issues as well, but they also have complete control of their own formulary, and people could complain to their senator about Blue Cross. They could complain to the Department of Managed Care in whatever state you live in. So there are ways to hold them accountable, but largely the Blue Cross of the world can have much more autonomy than the Medicares of the world, the Medicaids, because there's a little bit more oversight over them. So it's very complicated, and that's, again, back to the objectives for this talk is to give the patient the ability to advocate for him or herself as much as possible, so they're never surprised by what comes up, and they can pay attention. Like, maybe you live in North Carolina and maybe you never think much about the North Carolina legislature, what their control over North Carolina Medicaid is. But if all of a sudden you're a Medicaid patient and you're getting IVIG in North Carolina, that would be something you want to now pay attention to, because it could have some effect on you. They could change the way it's reimbursed. They could change the criteria. They could change how much out of pocket you're paying. Anything like that could change, and it could have a significant effect on you.
Yes.
So, sorry, Lauren, I didn't mean to.
No, that's okay. We have about 10 minutes. I'm actually going to take these two next questions and tie them into one. I'm going to ask each one first, and then I'll kind of answer, and then you can put your what you would like to add to that too, Dr. Rigas. So Wesley said, do you know when the COVID-19 antibody might be in the IVIG products? And then I'm going to tie this into Alma's question. with, not sure if this has already been asked, but could one get passive immunity from COVID through the IVIG? And I don't want to dive too deep into this, but I want to put it in layman's terms because I literally had this conversation several months ago and earlier this week on Monday with my immunologist at the NIH about this. And I want to go to the example of the flu vaccine. So Dr. Rigas, you already mentioned it can take between 9 to 12 months from start to finish to manufacture IVIG products or sub-Q products. And I had this conversation with my doctor and I said, why don't I get the flu? I've only had it one time in my life, and a lot of his primary immune deficient patients don't generally get the flu. And this is his theory. It's just a theory, but it makes really good sense. So most of the patients in the, well, plasma donors in the US, there's a significant number of plasma donors that get the flu vaccine every year, right? And then you have, and again, it takes 9 to 12 months to manufacture plasma. So his theory is that those antibodies that deal with the flu are helping protect some type of antibody in the IVIG product. And this is why a lot of his primary immune deficient patients don't necessarily get the flu. That's a theory. So his theory and hope is take the same concept and apply it to the COVID vaccine. In 9 to 12 months next year, his hope is there will be enough folks vaccinated that donate plasma that there will be antibodies in the plasma and can give a certain level of protection for primary immune deficient patients and other patient populations that rely on these products. Again, very short layman terms. Dr. Rigas, did you want to interject on that?
Yes, I may have wanted to talk about this earlier, might have not done it in any detail, but the IVIG is collected right now. The blood from about 10 to 20,000 patients is collected and pooled into a single batch, and then that batch is made into the IVIG that's available. So about 3 to 4 grams of IVIG come from every unit of plasma, every liter of plasma. So if you get a bottle, let's say 20 grams of IVIG, that's come from thousands of patients have pooled all their antibodies together, and that's what's in the IVIG. So somebody could have had measles, mumps, rubella, whooping cough. They could have had the flu. They could have got the flu vaccine and made antibodies toward the flu even though they didn't have it. They could have got a COVID vaccine now. They made antibodies to COVID that would be in the IVIG. And they could have gotten COVID in reality and made antibodies to the COVID. That would be in the IVIG. So the reason we give IVIG for immune deficient patients is primarily because it replaces what should be there that isn't, and that all the other things like anti-strep and anti-staph and anti-H flu and all the other infections it might get as a human, viruses and bacteria and fungus, there's antibodies to those things. So we would expect, as we said earlier, that it would take like 12 months. So 12 months from March of 2020, when the COVID first became a major thing, we're about 14 months after that now. So now we should start seeing COVID antibodies, anti-COVID antibodies in the IVIG. We've asked various IVIG makers if they're going to tell us how much is in there. That telling us that would be considered a titer, T-I-T-E-R, is the name that when you tell somebody it has this much anti-rabies, this much anti-rubella, anti-measles. If they would tell us how much anti-COVID-19 is in there, that would be important. I think they're not going to tell us because there would be a run, I think, on the IVIG that contains more of it, or if it didn't contain enough of it, people maybe try to stay away from it. So as of now, I'm not aware of any IVIG maker that is going to be sharing the anti-COVID antibody titer with anybody. They may be testing it and keeping track of it themselves, but as of now, as of this morning, I'm not aware that anybody's published it. There are other studies publishing things like how many anti-antibodies there are for other things, but typically it varies batch to batch. And even though you may have a high batch that is off the chart with a lot of antibody in this area, the next batch could be lower. So they typically tell you a range. And so yes, the question is there could be COVID-19 antibodies, anti-COVID-19 antibodies in IVIG should be showing up now. I don't believe anybody's told us how many or if they have it at all. And you could be getting COVID-19 immunity from IVIG if there was enough anti-COVID-19 antibody titer in there. But at this point, nobody is counting on that. That could be something that we count on in the future, but as of right now, that it's unknown, and that would not be a wise message to handle it that way. You would want to get your vaccine and or make sure that you had COVID and get your titers to make sure you have the anti-antibodies in there. It's concerning but confusing as to how long they may last. So some doctors, after a person's finished with COVID, they may still want them to get the vaccine months after they've survived COVID and are fully recovered. So, all right, so I think we're getting close to the 5-minute warning or even less. Lauren,
Yes.
do you want to ask other questions? I'm open and available.
Yeah, so we have time for maybe like one or two more. And what we don't answer, we can do offline, and I will email you directly once I speak with Dr. Rigas if we don't get to your questions. One thing I didn't want to dive deeply into is, and just touch on, is prescription assistance available programs for, patient assistance programs available for IVIG and sub-Q, because a lot of those are very, very expensive. And I, again, just briefly touch on this because we are short on a time. Did you want to say something about that, or did you want to save that for part 2, Dr. Rigas?
I will mention it briefly now, and then we'll delve into that in much more detail. So one of the main jobs I had for the last 5 years at my company was being the person who oversaw the trying to matching of our patients that required financial assistance with funds available from the drug makers, from nonprofit foundations like HealthWell, and also possibly some funds available from the pharmacy company itself, based on the programs and based on the regulatory requirements. So one thing we do, and when I show you this slide here, which we'll go into next time, but here is where we figure out what the patient's true out-of-pocket is after we get the referral, and then we decide the true out-of-pocket for the life of the prescription, not just for the year, because many times the patient may pay, say, $500 a month, and then after, say, June, they may be fully paid up and not have to pay anything for the rest of the year, and then it's going to happen again in January. So just when you think everything's good, you may be back in the hot seat again. So we're going to get much more detail about financial assistance here. These out-of-pocket costs were never intended for expensive drugs like this. They were intended for oral drugs where your out-of-pocket cost may be $25 or $50 or $100. They were never intended to make out-of-pocket costs where your out-of-pocket cost may be $5,000 or $10,000. And obviously that can become a significant deterrent for many patients who can't afford that. So trying to get assistance is important, and also important to note that if you have Medicare or Medicaid, the kind of assistance that could be available to you is very different than if you have managed care insurance and vice versa. So we'll go into that in much more detail next time, but it's very important to know because, especially with COVID, last year, many patients that might have been able to afford some or all of their out-of-pocket in 2019, they may have lost their job in 2020, and they couldn't have afforded anything. And so we had to work with lots of patients, hundreds of them, to look at their situation, look at their documentation, figure out how we could get money for them to help them from various companies. And it's quite complicated. So we'll go into that in much more detail in part 2.
Thank you, Dr. Rigas. And I do want to stress that AAIDA can be a resource for patient assistance and guiding you to those different programs or hoops patients have to jump a lot of times. So I just want to say thank you, Dr. Rigas, for being with us this afternoon and volunteering your time to educate our community. If we didn't get to your questions, I will follow up personally in an email and get those answered as soon as we can. Thank you for listening to today's webinar. Don't forget to tune into our upcoming webinars on May 21st for Sjogren's syndrome. It's not just dry eyes and dry mouth with Dr. Delphin Santos, and also on June 23rd for Chronic Illness 101, a young adult patient perspective with University of South Carolina Honors College sophomore Jessica Goddard. And also we will be posting what day we'll be doing part 2 of Dr. Rigas's IVIG Liquid Gold Forum soon, so do keep an eye out for that. And if you would please take a few moments to fill out our 4-question survey after the conclusion of today's webinar to help us better serve our community, we would greatly appreciate it. And also, please visit our website for resources and more information at www.godoaida.org. Thanks so much, and we hope everyone has a healthy afternoon.
Bye. Thank you.
Thank you.
Bye.